Good afternoon, everyone. Thank you all for joining the TxRx Echo brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT by Be Well Texas, in collaboration with UT Health San Antonio Echo program. My name is Angela Cruz, and I will be the facilitator for today's session. A few housekeeping items before we begin. Please do introduce yourself. Continue to introduce yourselves in the chat by entering your full name, affiliation, and an email. Please do remember to stay muted unless you are speaking. We encourage using the chat and/or raise your hand feature to pose questions, share perspectives, and resources throughout the session today. We'd love to see everyone with their cameras on as this increases connection and engagement. However, we do understand not every situation allows for that. So if you are able to, we'd love to see you. If not, no worries. If you're having any connection issues, please privately check Karen, our wonderful Echo IT, for further assistance. As a note, these sessions are being recorded and will be shared on our website for future reference. Additionally, therefore, to ensure privacy, no personal health information will be allowed at any point throughout the session. And this includes items such as names, addresses, birth dates, specific appointment dates, or any other identifiable information. And finally, the slides for today's presentation will be shared and uploaded on iEcho for future reference, and they will also be shared in our post-session communication email. So be on the lookout for that. At the end of the session, the ECHO team will be sending out a post-session survey link. We kindly ask and highly encourage you all to please complete it, as it does provide us insightful feedback and information on how to refine these sessions to better address your priorities and interests. We will continue with team introductions. Hub, when I state your name, if you could unmute and introduce yourself, please. I'll begin with our lead expert for today, Dr. Shorter.
Hey, good afternoon, everyone. I'm Daryl Shorter, Associate Professor of Psychiatry at Baylor College of Medicine and Medical Director of Addiction Services at the Menninger Clinic, as well as the Program Director for our Baylor Addiction Psychiatry Fellowship. Happy to be here.
Thanks, Dr. Shorter. We have Dr. Weems.
Hey everybody, John Weems Imbers here. I'm an internal medicine doc and addiction specialist here in Austin at UT Del Med and Community Care FQHCs.
Thank you, thank you. Dr. Waklu.
Good afternoon, Siddharth Waklu. I'm an addiction psychiatrist at UT Southwestern and Associate Chief of the Addiction Division and the Director of the Addiction Psychiatry Fellowship here. Thank you. Welcome, everyone.
Thank you. Dr. Walker.
Hi, Crystal Walker, doctorally trained PA and the Director of Substance Use Disorder Services, both clinical and medical for MHMR of Tarrant County, located in Fort Worth, Texas.
Thank you, Dr. Walker. And we also have Dr. Kowalczyk.
Hi, Alicia, Dr. Kowalczyk at Baylor College of Medicine, Department of Family and Community Medicine, boarded in Family and Addiction Medicine, and I'm also a medical director at Santa Maria Hospital. Thank you.
Thank you so much. And serving a dual role today, Dr. Chaudhary, he will be the didactic presenter as well as case presenter.
Hello, everyone. I'm Muhammad Ali Chaudhary, just Ali short. I am the Director of Adolescent and Youth Clinical Services here at Be Well, Texas, and an Assistant Professor at UT Health San Antonio. And today I'll be the presenter, and I'll also be presenting a case at the end.
Wonderful. Thank you so much, Dr. Chaudhary. And thank you all for those introductions in the chat. Please do keep them coming. We love to see where everyone's joining in from. And finally, ECHO is an all teach, all learn environment. We encourage everyone to participate in today's conversation and raise questions. Let us always make every effort to continue having the space that is respectful and safe for all of us to learn together. So with that, we'll get started with our didactic presentation. Dr. Chaudhary, the floor is yours.
Thank you so much. So I'm going to actually share my screen, and someone please give me a thumbs up if they can actually see the screen.
We see the screen. It's still okay. Now it's in the presentation mode. Looks good.
It is.
Yes.
Okay, perfect. Awesome. So I'll start off. So today I will be talking about cannabis use disorder in youth. why it is important, and how do we take care of it. Uh, all speakers and all members and the planning committee have no relevant financial disclosure as it pertains to this particular presentation, and the views expressed here do not necessarily reflect what UT Health San Antonio, the Department of Health and Human Services, Texas, hold, and we will try not to mention any trade names in here or any commercial practices or organizations that might imply any endorsement by the US government or the Texas government. So the objectives of today's presentation are first to explain what the endocannabinoid system is, what is its impact on the developing brain and why it's important. Um, the second thing is to outline the health impacts of chronic cannabis use in youth, and finally to discuss the treatment options for cannabis use disorder, especially in a younger population. So why do we even have cannabis receptors in your body, right? It's not something THC is not produced endogenously. So why do we have receptors for it? It's important to understand that. So the THC and other cannabis derivatives, they work on a system in your body called the endocannabinoid system. It's a fairly extensive system all across the body that uh, has its reach into the immune system, the inflammatory system, the nervous system, the gut system, like the digestive system, and all other systems, the endocrine system, and all other systems of our physiology. There are two basic types of cannabis receptors, although there are multiple types of cannabis receptors, but there are two main types that we need to understand. One is the CB1 receptors, and these are primarily the ones that are present um, in the central nervous system. They are present in your brain and the spinal cord, and these receptors are actually one of the most existent receptors in your central nervous system. They outnumber any other type of receptors in the brain. So it's a major player in your central nervous system, and they act almost like a volume switch or a volume knob that controls the level of activity or the level of activation of your brain. So the higher these receptors are stimulated, the lower brain activity becomes, the lower neuronal firing becomes, and the lower the release of other neurotransmitter becomes. What do they do? They regulate pleasure, they regulate mood, they regulate pain, appetite, motivation, memory, and alertness. So a lot of things. The other type of CB receptors are the CB2 receptors, and these are receptors that are present actually widely across the human body. And they are primarily in the immune tissues, and they regulate immune function, they modulate intestinal contraction and inflammatory responses. And one of the things that's actually up and coming in terms of research is that in the central nervous system, there's not a lot of CB2 receptors, but they do happen to show up when there is some type of cellular injury, and they are also associated with certain types of psychotic disorders if they are present in the central nervous system. And the role of the endocannabinoid system is in a developing brain is to shape the development of the brain. So how it does that is it selectively turns down the volume on certain neural pathways that are not used, that are either redundant or they're not useful to the brain's development. So in a way, it's guiding neuronal development. So it guides them which pathways to keep, which pathways to prune away when the brain is developing. It also controls neuronal activity, so it basically affects brain wiring. So the neurons that fire together, they wire together, which means that it does lead to connection between certain neurons and stops the connection between others. And finally, it leads or supports the development of myelin around neurons. So myelin sheath is a protective sheath that basically encapsulates the nerves, and it is an insulator that protects it from outside influence, and it is a marker of completion of brain development. So basically, the endocannabinoid system has an important role to play in the development of the human brain or in shaping the development of the human brain. Now, the question becomes, why do we have it, right? And the answer to that is that the brain has a chemical called anandamide, or they have different endocannabinoids, the most important of them being anandamide. And this is a chemical that is um, um, secreted uh, in a very localized manner in your brain where the activity is going above what's considered normal. So if a certain part of the brain is overfiring, locally anandamide is released, and this gives a signal to the cell that's overfiring to calm down a little, right? So to reduce the amount of firing in that area. So that's and that makes it very important. So it keeps the brain in check. But then when you take THC, which if you look at it is eerily similar to the structure of anandamide, it tricks the brain into thinking that this is anandamide and this is fat soluble. So it has ease of access to the central nervous system. So it directly goes to the central nervous system. And now this is acting globally because anandamide, as I said, was secreted locally, whereas THC, it acts on the brain globally and it gives the whole brain the signal to calm down a little, right? That's why you feel that relaxation effect and sedation when you consume THC. Uh, but in a developing brain, this also confuses the brain as to what parts of the brain to prune, the non-used or redundant parts of the brain, right? But when you're taking THC, the brain doesn't know which part is not used because all of the brain has their activity, all of the brain has its activity coming down. And there is a difference between anandamide and THC. Delta 9 THC is the active form of THC. So the difference is that THC is 2 to 3 times more potent than anandamide, which means that if anandamide is like a scalpel, it's precise, it is secreted very locally in certain parts of the brain where it is needed at certain points in time, and it has a very precise action. THC is like a sledgehammer because it acts on the whole brain and it is way more potent than anandamide. And what are the effects? Now, if you look at it, these yellow dots on this image are all the CB1 receptors across your brain. So if you look at it, it's all over the place. And that's why you have almost a global effect of THC when it is consumed. It hampers coordination, it hampers your sensations, your movements, your judgment, and it takes over the reward pathway. And what happens if you keep on using THC? So when you keep on using THC, you're inhibiting the brain activity, the neuronal firing again and again. And what that leads to is that the brain gets confused because it's getting inhibited again and again, and it tries to compensate for it and bring it back to equilibrium. And now all of a sudden your excitation is super strong. Like the excitation network in your brain becomes super strong. And if you stop consuming cannabis at that time, the inhibitory pathways in your brain are not as strong and the excitatory pathways become super strong. So it's almost like it goes into hyperdrive. Um, and other than that, there are some impacts of cannabis that are due to long-term use of cannabis. So we're going to discuss some of them. So I'll start off with this study that persistent users of cannabis show neuropsychological decline from childhood to midlife. So in this study, they basically followed people up from pre-initiation of cannabis, and it could have been as early as 13 years of age, and they followed them up into late into their adulthood, and they did assessments at different time intervals. And what they found was, you can find that in that small little rectangle in the slide, where people who don't use cannabis compared to people who don't use cannabis at all, regular cannabis users, which is defined as more than 3 years of use, had a significantly lower IQ. So it had a direct impact on your IQ. And one of the things that's not on our slides is that this impact was stronger the earlier the use of cannabis was. So if your use of cannabis was earlier, let's say it initiated at 13 years of age versus if it initiated at 16 years of age, the earlier you started using cannabis regularly, the higher the impact on your IQ was. Another side effect of cannabis in youth that is very important is its association with psychotic disorders. So if you look at it, on the left side of the brain is the functional MRI of the brain of a healthy person who does not use cannabis. And on the right side, you have a regular cannabis user. And the part of the brain that's depicted in there is the corpus callosum. This is the bridge between the right and the left hemisphere of the brain. And the colored part basically represents the activity of the brain, not the structure of the brain. So if you look at it, because it's a functional MRI, it is depicting the activity of the brain. And if you look at it, the people who use cannabis regularly, they have thinning of this corpus callosum, or like at least functionally, it is not as active in people who are regular cannabis user as compared to healthy adults. And this is very similar to the fMRI patterns that we see in people with psychotic disorders like schizophrenia. They also have thinning of their corpus callosum because this is the data highway of your brain. This is the cable that connects the right and left hemisphere, and it is responsible for normal cognition. So any impact to this can lead to psychotic disorders. And that's why we see that in a meta-analysis, which is a study of studies, so it collates data from different studies. So in this meta-analysis of 6 different studies, it found that people who used cannabis regularly had almost twice the adjusted odds of developing a psychotic disorder compared to people who do not use cannabis. So you're twice as likely to develop a psychotic disorder compared to people who don't use cannabis. Another side effect of regular use of cannabis is a syndrome called cannabinoid hyperemesis syndrome. And so this is a syndrome in which you have bouts of nausea, retching, and vomiting. And these bouts are sometimes associated directly with the timing of cannabis use, and sometimes they're not associated with the timing of cannabis use. Uh, um, and the only thing that seems to make it better is actually taking hot showers. And regular antiemetic medications or medications to control nausea do not act very well in these situations. And the only way to achieve complete recovery from this cyclical nausea and vomiting episodes is to actually completely abstain from cannabis. And you start feeling the improvement in days to months actually after you stop using cannabis. Other long-term impacts of cannabis, as I said, the cannabinoid receptors are all across the brain. So that's why you have impacts that are associated with different parts of the brain. So you have less emotion control over your emotions, worse problem-solving skill, slower processing, lower verbal comprehension, and poorer memory. Now, I also want to talk a little bit about when we talk about cannabis, we need to talk about the same thing. So, the cannabis of 30 years ago is not the cannabis of today. The cannabis of 30 years ago only had close to 4% THC content. I'm talking about the regular flowers or buds of cannabis. They had around 4% THC content. But the cannabis of today, this data is up until 2019, but we have more data up to 2022. And we see the amount of THC in cannabis now is up to 17%. So it's not even the same drug anymore because the quantity of THC has almost increased by 4 to 5 times. And then when you talk about cannabis vapes or THC vapes, they are 90% or more pure THC. And so that's a different drug altogether. And the other important thing to remember about cannabis or marijuana is that the association that we see in alcohol use disorder, where the earlier you initiate your first alcohol drink, the more likely you are to develop a alcohol use disorder, holds true for cannabis as well. Though the effect is not as strong, but the effect is still there. which means that if your first use of cannabis is before or at the age of 13, you have almost a 17% chance of developing a cannabis use disorder compared to only 4% chance of developing a use disorder if your first use was after 21 years of age. The other thing that we also need to understand a little bit about is cannabis withdrawals. So, cannabis withdrawals can be a little tricky because they don't happen right away when you stop consuming cannabis. In the first week after cessation, you might experience nothing. You might start feeling some withdrawals, but you might not experience the full extent of those. Week 2 and week 3 are the part where you have the worst of the withdrawals, and week 4 is when the withdrawals start subsiding. The withdrawals can look like irritability. You can have increased anxiety, feeling on the edge. You can have some depression. Insomnia is a major factor. And then you might have decrease in your appetite and some weight loss, and you might also have flu-like symptoms. Here's a timeline of different withdrawal symptoms, which we will not discuss today. Now, let's talk about what can we do about the treatment of cannabis use disorder, especially as it pertains to the youth. So first of all, I want to make sure that everyone knows there's no FDA-approved medications for cannabis use disorder. There are medications that have shown promise and that have shown to be effective in studies, but we still don't have an FDA-approved medication for this. So what are those medications? So one of those medications is N-acetylcysteine. This is an antioxidant, and it actually is in the oral form is sold as an over-the-counter supplement. A lot of adults take it as a detoxification agent. It's basically like drinking pomegranate juice. But in the case of teenagers, for some reason, it has shown that it leads to decreased cravings and decreased withdrawals from cannabis. The dose at which an acetylcysteine is to be taken is 1200 milligrams twice a day. And the only major side effects of an acetylcysteine are a bubbly stomach for the first week or 2 weeks of use, but your body gets used to it afterwards. And some teenagers report that it has an activating property to it, so they feel like a buzz when they take this medication. But other than that, there's no major side effects to consider when you're giving an acetylcysteine. Um, what should you consider when you're giving an acetylcysteine? So one thing to consider is that this medication is only effective in people who are younger than 21 years of age. So studies have not demonstrated any significant benefits for people above the age of 21. And the younger you are, the more likely it is that it's going to be effective. It has to do something with your brain development. We don't exactly know the mechanism by which it leads to decreased cravings and decreased withdrawals of cannabis, but it happens to be effective more in younger people than in young adults. Uh, but what if you do have a young adult, or what if N-acetylcysteine has not been effective in a younger teenager? You do have the option of considering gabapentin. Gabapentin has some impact on cravings, but primarily it helps with the withdrawals associated with cannabis. You can give it at a dose of 5 milligrams per kilogram per day, with a maximum dose of 300 milligrams per dose for younger people, up to 3 times a day. And you can titrate it up from there as required. And then finally, you have naltrexone, which is an opioid blocker. This is a medication that is useful pretty much with all types of substances because it blocks the pleasure pathway associated with most of the drugs. Now, it is primarily used for alcohol use disorder. So if someone has alcohol use disorder and cannabis use disorder, it becomes an easy choice to consider naltrexone. The other consideration about naltrexone is that this is an opioid blocker. So if someone is on any prescribed opioids or recreational opioids, they cannot be given naltrexone right away because it might put them into precipitated withdrawal. If you have a surgery coming up, which would require you to be on opioids or any other thing that would require opioid prescription, the person needs to be off the naltrexone during the period when they're on opioids and they can restart afterwards. So these are some medication options that can be considered. Uh, but other than that, the more important part about treating cannabis use disorder is the behavioral interventions. So for people who are not yet completely sold about the idea of therapy or not sold about the idea of abstaining from their cannabis use, motivational enhancement therapy is a good option. This is a technique in which you try to find a motivation from within the person themselves and then try to build upon that, solidify that motivation, enhance that motivation over time. The idea is not to push. The idea is not to cause any discomfort, emotional discomfort to the patient. And this works well for people who are ambivalent or who are not yet ready to commit to treatment. But for people who are already enthusiastic and they want to engage, they are more engaged in terms of their treatment. Cognitive behavioral therapy has been shown to be very effective in cannabis use disorder. Cognitive behavioral therapy is the type of therapy in which you're trying to fix the thought processes that lead to certain behaviors that also lead to certain pathologies. So you're fixing that problematic thought process. It does require the patient to be a little more engaged and a little bit open to the idea of therapy and to the idea of achieving remission and recovery. And then finally, contingency management is another thing that has shown some promise in the case of cannabis use disorder. This is a mode of treatment in which you provide small monetary rewards for certain desired behaviors. And the idea is to trick the brain into getting a dopamine hit without the use of that particular substance. So, for example, if they show up for their appointments like 3 times in a row, they get a monetary reward. If they show up for their group visits or their therapy appointments for a month, they get a monetary reward. If their drug test is negative for cannabis, they get a monetary reward. And the idea is this works like operant conditioning. So the idea is to train the brain into finding pleasure in desirable behaviors rather than the undesirable behaviors. And it's shown to be effective, and it's especially shown to be effective for substance use disorders for which we don't have good medications for, cannabis being one of them. And then there are a whole host of interventions that are not directly related to psychotherapy or medications. Collateral support is very important. So if you have a teenager, you should use all levels of support. So this should include the criminal justice system if they're already engaged with it, the school system, and especially the guardians, parents or other guardians, because they can shape their home environment and their school environment in a way that's more conducive to recovery. So parental support, parental guidance or guardian guidance is very important part of the treatment so that they can change that home environment that focuses on recovery, that focuses on engagement rather than punitive measures. And if you can fix the dysfunction at home, chances are that they're more likely going to achieve remission and recovery. Accountability is also very important, especially in the cases of teenagers, because their prefrontal cortex, so the part of the brain that's responsible for uh, um, risk assessment, is not yet completely developed. So you have to provide them some external accountability. So for that, you can do regular drug testing. Um, uh, I generally recommend doing quantitative drug testing if possible, because for cannabis, your drug test, if it's not quantitative, might just turn positive for up to 6 weeks after they have completely stopped using. So if they consistently have positive tests even after they have stopped using cannabis, it might be a little demoralizing for them. But if you have a quantitative test, they can actually see their progress over time. They can see the number of the amount of THC come down over time in their drug test results. And then having regular follow-ups whether it's with the medical provider or the therapist, is very important because you want to provide them some structure in their life. And that regular follow-up does provide some structure that can be helpful. These are some of my references. Thank you so much. And I'm more than happy to answer any questions if you guys have any.
That was excellent. Thank you so much, Dr. Chaudhary. Lots of hand claps, virtual hand claps for you. Thank you. Any questions, comments, or follow-up thoughts for Dr. Chaudhary on his presentation?
Dr. Chaudhary, this was an excellent presentation. Very beautiful, very, very well done. And what is your experience with NAC? How well does it work for kids less than 21?
I think I have had like really good. I've been seeing like younger and younger patients recently, and it seems to work very well for the young people, like the ones that are like younger than 16 years of age. It works like really well for them. Or at least like maybe it's a placebo for me that I think it works well for them. But generally I've seen it to be super effective. I think in these late teens, it's effective. It does give them that like that routine to follow, to take that twice a day. If they're following you up on this, that means that they're more responsible. The chances are they're going to be responsible with other things as well. So it might be confounded by that. But I think for people above the age of 21, I don't even prescribe that, or I don't even recommend that they take it because it's not going to be much use. 16 to 21 is that age. I still give it to them. If it works as a placebo, let it work as a placebo. But younger than 16, it seems to be fairly effective.
Thank you.
Thank you, Dr. Shire. That was awesome. I wonder if you could speak a little bit about patients, especially adolescents, young adults who are presenting with psychotic symptoms in the setting of frequent cannabis use, particularly these high potency THC products that you mentioned earlier. Thank you so much.
Oh, absolutely. So, I mean, with psychotic disorders, the chances, so there's a study that shows that if you have had like any of the psychotic symptoms when you're using cannabis, and you don't have to have full-blown psychosis, but like, let's say you had like, significant paranoia, or you start having hallucinations. If you've had it once and you continue your consumption of cannabis, you have almost a 50% chance that you are going to develop a psychotic disorder, like either bipolar disorder or schizophrenia or something like that. So it is definitely something that we see a lot of. In terms of, does it get reversed by, first of all, do we know if it's causative in nature? We can't really like say it's causative, but we definitely can say that there's a strong association with cannabis use. It definitely hastens the emergence of these symptoms in people who are more likely to develop them to begin with anyways, right? And also the thing is that it opens that door. The way I explain it to them is that it opens that door of psychosis, right? And you open it once, maybe it closes when you stop using cannabis, right? You open it again. The more you open it, the looser the hinge becomes, and the less the chances are that it's going to stay closed afterwards, right? So the more number of times you actually enter psychosis from that particular substance use, especially cannabis, chances are you're not going to go back to having no psychosis even when you achieve abstinence. And then yes, I do give for people uh, who come in with psychosis, I do start with like a short course of antipsychotics, and like with all the other things that we're doing. And I think after the first episode of psychosis, I do give like 6 months of antipsychotics and then taper them off of it. And then afterwards, like if they have persistent psychosis or they develop psychosis again, then I continue long-term antipsychotics for them.
Thanks for that question, Dr. Weems. Oh, go ahead.
Sorry, I can't find my hand raise thing
Oh, that's okay.
on my Zoom. I just wanted some comments on thoughts about combination therapy. Would you ever use, for example, gabapentin and naltrexone together in an older adolescent or young adult? Your thoughts
Yeah.
on approaching that?
Yeah, actually, a lot of my patients, like, you're trying to throw the kitchen sink at them, like in the beginning. So yes, I do use like naltrexone and gabapentin together with them, especially because naltrexone works more towards like, the craving aspect of things, whereas gabapentin is more for the withdrawals associated with abstinence. So I do give it together in the beginning. And then naltrexone is something I do want kids to be on because it's also like a safety check, even though it's not as good as Suboxone or methadone when it comes to preventing overdoses from contamination, but it still provides some benefit in terms of these people who have like polysubstance use with like they're either using pills or like they're using all sorts of different kinds of like cannabis that have the chances of having contamination in there. So naltrexone is also a safety check in addition to preventing cravings and those sort of things.
Dr. Chaudhary, thank you for your talk. And speaking of safety checks, I'm wondering if you can give some clinical pearls about drug monitoring and drug screening. It seems like one of the things that I get asked about frequently from other clinicians and colleagues is like, how do I make sense of urine drug screen results where we might be looking at a positive cannabis UDS for 30 days, 45 days?
Yeah. Yeah, no, I think that's an important question. For me, like in the program, we have the resources to do quantitative tests. So I personally prefer quantitative tests because it's a motivation for them. It's almost like gamifying the test for them. These tests are adjusted for the concentration of the urine. So these tests you can use that number to compare it across different UDS results. So over time, they can look at their progress if the numbers are going up or down. Sometimes they say that their use has not changed, but their numbers are going up. So we need to figure out like whether the products have changed for them or if they're just like, inadvertently using like, you're taking deeper hits or like more hits of it without realizing it. And then we need to figure out what's making them use more, whereas they didn't think they were. So is it like a stressor in their life? So quantitative tests are like really helpful with regards to that. And if possible, we should be doing quantitative tests. But if in certain situations it's just not possible, and in those situations it's important for clinicians to know that the test can actually be positive up to 2 months after they have had complete abstinence, right? So it's like you shouldn't be penalizing people for a test that's positive because they used 2 months ago, and the only way you can tell what the real value is by a quantitative test. So if you don't have a quantitative test, do not penalize them if they're telling you they're being abstinent and it's still turning positive beyond like, like the 1 month mark. Generally, everyone knows about 1 month, but we've had patients who've been positive, like, up until like, 6 weeks, 7 weeks into their abstinence.
Thank you so much, Dr. Chaudhary. And we will continue this cannabis use treatment and conversation in our case, not to give too many spoilers, but for now we will move on to announcements. If you have any more questions or thoughts for Dr. Chaudhary, please put those in the chat. But Karen, when you have a moment, if you can pull up those slides for us, please. Thank you. Okay, so to claim your CME credits for today, please ensure that you have a registered account. This is an imperative step in order to receive your credits. For today's session, once you confirm that you do have your account, please text attend 10101416 to 844-502-1338 no later than midnight tonight. This process is the same for all of our sessions, but it's imperative that you confirm you have your account first, and then you follow up by texting the code that we share during these sessions the day of the session in order to receive your credits. Next slide, please. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics. To request technical assistance, please complete an online request form using the link that will be shared in the chat or by scanning the QR code at the bottom left of the screen, and we will be pleased to help you. Next slide, please. CSET offers the wonderful opportunity to present any challenge your organization is encountering and to receive live feedback from our hub of experts and broader learning community. There is no need to prepare a formal presentation as we do provide you with the case form to fill out to assist you with your case presentation. If you're interested or know anyone that would be interested in presenting a case, please email us using the link that will be shared in the chat shortly. Next slide, please. Registration is open for the 2026 Texas Substance Use Symposium. We invite you all to join us March 2nd and 3rd at the Henry B. Gonzalez Convention Center in San Antonio, Texas, for 2 days filled with learning, collaboration, and connection. To learn more, please visit the site using the link that Karen will be sharing in the chat. Next slide, please. And as a follow-up, all professionals across the fields of substance use and behavioral health are invited to submit a poster proposal for Texas 2026. The poster submission deadline has been extended, and we are now accepting proposals through January 25th, which is this Saturday? No, which is soon. It's coming up because it's January 22nd. Share your expertise, innovative practices, and research with a statewide audience dedicated to advancing recovery-oriented systems of care. Learn more using the hyperlink in the chat or by visiting texas.org/symposium. Next slide. And partner with Texas to showcase your organization, support statewide collaboration, and connect with substance use professionals across Texas. For more details on sponsorship and exhibitor opportunities, please contact us at texas@uthscsa.edu or visit the site shown on the lower left of the slide. And the last slide, thank you. Please join us for our next session presented by Dr. Shorter on February 12th for a presentation on treating stimulant use disorder in youth. Thank you, Karen. And now we'll move on to our case presentation for today. Dr. Chaudhary, I'll pass the mic back to you. And once Karen shares the slide, you can walk us through it. Thank you.
Okay, thank you so much for sharing, Karen. Today's case presentation is about a 21-year-old Caucasian male who presented to us in our youth clinic for problematic opioid use and problematic cannabis use. This patient, when they came in, they already had a diagnosis of opioid use disorder, were on buprenorphine, naloxone, um, um, 8 milligrams twice a day, and they had problematic use of cannabis. They were already getting some psychiatric care, but because of changes in insurance, they had some lapse of care in between, and now they were showing up to our clinic to continue on their care. In terms of their substance use history, they had tried cocaine once, had a daily use of nicotine since the age of 14 in the form of vapes. Cannabis from the age of 13 daily in the form of buds, flowers, so smoked cannabis from 0.5 to 1 gram a day. And then the opioid use, which was now in remission, was since the age of 15, and they were using fentanyl pills, no IV substance use, up to 20 pills a day, and currently on Suboxone 8 milligrams twice a day, buprenorphine 8 milligrams twice a day. So the primary diagnosis was definitely severe opioid use disorder, for which they were already on treatment by the time they came to us. We just continued that treatment. And the secondary, more significant diagnosis right now was the severe cannabis use disorder. In terms of co-occurring mental health disorders, they had a history of major depressive disorder, generalized anxiety disorder, PTSD, and bipolar disorder. In terms of medication for substance use, they came in with with buprenorphine 8 milligrams twice a day, and in addition to that, we started them on gabapentin 100 milligrams 3 times a day, which we'll talk about a little later. Uh, they came to us after completing 39 days of residential treatment. No history of any kind of psychotherapy in the past, at least not long term, like more than 1 or 2 sessions. And currently, we started them on individual therapy, some parental guidance, which we'll talk about a little later. Um, um, Other than that, they are used to going to NA meeting since discharge from the residential treatment facility, and they have Narcan at home and have had overdose prevention education already. So the patient lives with mom and an elder sister, and support systems include mom. The patient is 21 years of age, but chronologically, but like developmentally much younger than that, so completely dependent on mom at the moment. He has transportation available, living situation is stable. He's going to trade school for HVAC training. And as we talked about, psychiatric history of major depressive disorder, generalized anxiety, PTSD, and bipolar disorder. We did check the prescription drug monitoring program. It was consistent with just buprenorphine prescription in the past. Pertinent findings include that mother is a major support structure, so leveraging her for help will be critical in terms of helping this patient. And the other thing was this dysfunctional permission structure the patient has for cannabis use, because everyone at home uses cannabis. So that might be an impediment to abstinence from cannabis for this patient. In terms of current medication, they're on buprenorphine 8 milligrams twice a day for opioid use disorder. We started them on gabapentin 100 milligrams TID for cannabis use disorder, with some help for generalized anxiety disorder as well. They are on Seroquel 400 milligrams daily from the previous psychiatric care that they had for their bipolar disorder, and Buspar 10 milligrams BID, which they report to be ineffective for their generalized anxiety disorder. And the patient has not been taking that for a while now. No significant medical comorbidities. And our treatment plan for this patient was to start them on gabapentin at a relatively low dose to make sure that they don't experience any side effects from gabapentin, have a close follow-up in 2 weeks time period to escalate the dose of gabapentin if needed, to help with the withdrawals of cannabis, and also some uncontrolled anxiety that they have right now. We continued the buprenorphine 8 milligrams twice a day for the opioid use disorder. We initiated regular UDS testing and medical follow-ups for this patient, and they had already had an intake with the with the therapist at our program, and so we basically paired them with a therapist who was trained in EMDR for better like trauma related therapy for this patient, especially with a history of PTSD. Also gave him referral to psychiatry for reevaluation and management of the bipolar disorder, PTSD, generalized anxiety disorder, and major depressive disorder. And we have scheduled an appointment for the mom. The patient signed an ROI for the mom so that we can provide some parental guidance, especially as it pertains to the home environment, which is right now very permissive about cannabis use. So we want to change the home environment in a way that becomes more conducive to recovery. So I'm open to thoughts, suggestions, what could have been done better,
Thank you, Dr.
what should be
Chaudhary.
done. And
Excellent.
this is
Yes.
a so just wanted to say this is a new patient, so I've seen the patient once, so your recommendations would be really helpful because I'm gonna implement them as we go along.
Dr. Waklu, go ahead.
Uh, Dr. Chaudhary, does the patient feel that the family members also have a cannabis use disorder?
No, the patient feels that the family members don't have a problem with that, but he does have insights that he has a problem with it.
Okay.
Yeah.
So, okay, so the family cannabis use is primarily social and not problematic.
Yes. At least from what the patient's perspective is.
Where does he buy his cannabis from?
That's a question that I did not evaluate for him. Uh, but that's something that I'll ask the patient and or the mom when I see the patient and the mom.
Yeah, thank you so much for the excellent case.
Lena, if you could unmute and elaborate on your question, please.
Mute. Yeah, I mean, just I've been um, listening to some continuing education videos on bipolar disorder and bipolar depression. So he said bipolar, didn't say bipolar 1 or 2, and major depression. So those are two new medications that might be used because quetiapine has a lot of negative effects. So maybe something newer would help this patient.
No, I agree. I think he definitely needs better psychiatric, management of his psychiatric medications. Um, uh, so because we have easy access to psychiatric care, like adolescent and young adult psychiatric care here at UT Health, so rather than like changing any of the medications myself, I just sent them to like a psychiatrist. But if the issue was that we couldn't get them to a psychiatrist early enough, I would have definitely changed the psychiatric medications for this patient. And it is bipolar 1.
Thank you for your question, Lena. Dr. Shorter?
Yes, thank you for your case presentation and for the questions so far. I had a lot of thoughts and questions about the psychiatric presentation of this particular case. In our huddle prior to discussing the case here, I raised the question about the nature of the trauma that resulted in the PTSD diagnosis. I don't know about you all, but I feel like I'm seeing more and more diagnoses of PTSD for folks that maybe don't necessarily have a criterion A traumatic experience. Sometimes people might say things like capital T trauma versus lowercase t trauma. There are lots of different kinds of traumatic experiences that folks might have. But when we're really trying to clarify diagnostically what's going on with someone, I do think it is important that we confirm the presence of a criterion A traumatic experience. And this becomes particularly important to clarify the diagnosis regarding PTSD because as it stands right now, the patient is on no FDA-approved medications for PTSD. So the PTSD is essentially untreated at this time if there is actual PTSD present. So I think that becomes a question that we would certainly want answered. Of note, the FDA-approved medications for PTSD are sertraline or Zoloft, as well as paroxetine or Paxil. And so looping those medications in might be something that needs to be considered. I love the question about bipolar depression. In this case, I always have questions about bipolarity and the accuracy of that diagnosis in cases where people have been using substances extensively. So when was that diagnosis of mania made? What was the context for it? What was the substance use like in that context? Dr. Chaudhary did a really great job of helping us to understand the increased likelihood of the development of psychotic symptoms in the context of cannabis use. And so again, I have questions about the nature of this bipolarity. Not to say that it's not there, but just can we better understand the underpinnings of that diagnosis? Dr. Chaudhary also mentioned that if someone presents with psychotic symptoms in the context of cannabis use, he will sometimes give them a trial of medications for about 6 months and then discontinue that medication for people. We don't necessarily want for people to be on second generation antipsychotics indefinitely, just because they had the development of psychotic symptoms or manic symptoms in the context of substance use. And so the psychiatric referral is completely on target. And my hope is that we get a little bit of a follow-up after that assessment, because I think that there are more questions than answers at this time. The sort of the easiest part of this whole case, frankly, is gabapentin 1,200 milligrams a day, 400 milligrams TID. Like, just let that ride to manage cannabis cravings and cannabis withdrawal. But really, what are we dealing with in terms of PTSD and bipolar disorder? The final point I'll make about PTSD is that in the state of Texas, PTSD is a qualifying condition on the Compassionate Use Registry of Texas. And so we really want to make sure that we understand the nature of PTSD, because there are some providers who would recommend that the patient actually utilize cannabis to treat their PTSD. And that he would be able to get a prescription for, a prescription card for, and have access to a dispensary for obtaining cannabis to treat PTSD, if it is in fact an actual diagnosis. So we begin with diagnostic clarity and then go from there. Thanks.
Yeah, thank you, Dr. Schroeder. That's really helpful, and I think you're right about that. The PTSD, like inciting event. I think the inciting event, as mentioned by the patient, was his sibling dying, who was pretty close to his age, and I think they died from an overdose. And that was, at least in their mind, that was like the inciting event for their PTSD. And um, um, other than that, like, I think you're right that we need more diagnostic clarity in terms of their mental health conditions in order to make sure that we're not over-treating or over-diagnosing these patients.
Excellent. Any other thoughts or questions from the audience?
How will you diagnose the PTSD? What criteria do you use?
I'll go. Yeah. So I'd be interested to know, first of all, if this traumatic experience was witnessed, or was this something that the patient heard about? We've all perhaps experienced the trauma of losing a loved one, and certainly that you can experience psychological trauma related to loss and grief, but we are really talking about the sort of the terror that one experiences in the context of a traumatic experience, or the complete loss of control that someone might experience as a result of exploitation. And so I would really start with trying to understand the nature of that traumatic experience, and then I would go on to the development of hypervigilance as a result of that, a shift in one's mood, alterations in cognition as a result of that. So I think that I would just go back to DSM-5 and really try to tease that out. But it begins with criterion A. And the tricky part about all of this is that sometimes people can have the hypervigilance, the alterations in mood and cognition, and the avoidance, but not have a criterion A traumatic experience. And I think that those become the most challenging cases to really tease out when we're talking about PTSD. I will add in the minute that we have left that although we sometimes utilize the language and the diagnosis of complex PTSD, it's not yet in the DSM-5. Maybe it will end up in the DSM-6 down the line. So CPTSD is, again, another really kind of difficult psychological diagnosis, and one that I think should be carefully considered.
Thanks so much for that question, Berna, and for that wonderful answer, Dr. Shorter. Dr. Shorter, would you like to give us a quick just summary
Sure.
of today,
Yeah,
please? Thank you.
absolutely. We had a great talk about cannabis use disorder, both neurobiological understanding of it as well as its overlap with psychiatric conditions. I think cannabis is perhaps one of the most complicated things we're seeing in our clinical settings these days because it feels like everybody's using it and everybody's experiencing psychiatric symptoms related to it. The case, I think, was a great reflection of that complexity with someone who has both depression and bipolar 1 disorder, anxiety, as well as PTSD, and really getting appropriate psychiatric assessment, utilizing the resources that we have available to us with the DSM-5, making sure that we're not overprescribing or underprescribing, and using off-label medications like gabapentin and NAC for those who are under the age of 21 is really the best bet when managing these extremely, extremely complicated cases that are increasingly coming through our doors. So great job, Dr. Chaudhary. We really appreciate your work today. Thank you.
Excellent summary, Dr. Shorter. Thank you so much. Thank you to everyone that's attended today's session, to our presenter, Dr. Chaudhary, for the wonderful didactic and the case that tied in as well. That's wonderful when that happens. As a reminder, to claim your CME credit for today, please text by today at midnight, text attend 101-01416 to 844-502-1338. We also kindly request that you complete the post-session feedback survey using the link that Karen shared in the chat. We look forward to seeing everyone at our next session on February 12th, and have a wonderful rest of your week, everyone. Thank you.